standardized interview form to collect the information. And numerical rating scale was used for pain scoring. And how do we perform pain scoring? We will ask the patient to rate the pain verbally without looking at the scale from 0 to 10. However, in some patients, they were having hard time imagining the pain in numbers. So in this case, we will have to show the visual skill. As you can see here, pain score of 1 to 3 indicates mild pain, 4 to 6 moderate pain, and 7 to 10 severe pain. And this is the flow chart of data collection. Firstly, we will identify and approach patients on their arrival, and then once we know that they fit the criteria, we will explain them about the study and obtain a consent. Then we will start interviewing the patient regarding the pain site, the pain score, and etc. And then we'll also check the analgesic prescription. Besides, we'll also obtain the pain score at specific intervals up until their disposition from emergency department, whether they are discharged home, admitted to ward, or kept in the observation room. Then finally, we'll wrap up the interview by checking the analgesic prescription upon their disposition. For the result and discussion, in our study, males were more than female. And for the pain side, in the trauma-related cases, the upper limbs and lower limbs were the main sources of pain, whereas for non-trauma related cases, abdomen was the main source of pain. And overall, abdomen was still the commonest site of pain in patients. And about 1/4 of patients, they took analgesic before arriving in ED UKMMC. And about less than half of the patients, which is 44%, they were prescribed analgesic by the ED personnel and doctors throughout their stay in emergency department. And our finding was consistent with the previous studies, which recorded 30 to 63% of analgesic prescription rate. And there are also other important findings. 33% of patients with severe pain were not prescribed analgesic, whereas 66% of patients with moderate pain were not prescribed analgesic. So the above two findings, combined with the low overall analgesic prescription rate, indicate the underuse of analgesic in ED UKMMC. On the other hand, upon the patient's disposition, majority of them were prescribed analgesic. We also compared the pain score between patients who were prescribed analgesics and patients who were not. And in this study, it is found that in patients who were prescribed analgesic, they recorded a higher pain score on arrival, and they recorded a lower pain score upon disposition. So it means they recorded a greater reduction of pain. So we compare the mean reduction of pain using the independent t-test. It is found that the reduction of pain, the average reduction of pain, were significant between both groups. And we also assess the pain evolution upon discharge, and we adapt the classification used by two previous studies, where the change in pain score is -2 or more, pain is considered relief. -1 to +1, the pain is considered stable. And if the change in pain score is +2 or more, the pain is considered worsened. So in this study, we can see that about only half of the patients, which is 49.5% of them, achieved pain relief. And the other half of them had either stable or worsened pain. And majority of those achieved pain relief, they come from the group who were prescribed analgesic. And for those who did not achieve pain relief, majority of them came from those who were not prescribed analgesic. And out of those 49.5% of patients who managed to achieve pain relief, we asked them whether they are satisfied towards the adequacy of pain relief they obtained. And it is found that 93% of them are either satisfied or very satisfied with the pain relief they achieved. In other words, 93% of patients who achieve pain relief claim that the pain relief are sufficient. Only 7% complain that the pain relief were not sufficient. And we also managed to identify the pain relieving agents used in our ED. and we divide them into analgesics, which is 5 of these, and also analgesic adjuncts. They are not true analgesics, but they do confer pain relieving effects, so we include them in the study. And we also look at the rate of pain relieving agents prescription in ED. It is found that NSAIDs recorded the highest rate of prescription, followed by opiates and tramadol. Opiates are predominantly prescribed in patients with severe pain. And upon disposition, NSAID was still the most commonly prescribed analgesic, followed by acetaminophen and tramadol. And in conclusion, we didn't find any universally accepted benchmark to judge whether the pain treatment is adequate or not, but from the statistic I show you, it is safe for us to conclude that oligoanalgesia still exists in ED UKMMC. Among the factors are lack of proper assessment and lack of practice guideline, and this can be improved by developing a pain assessment tool and a protocol on pain relief. Thank you. Any questions?
I have two questions.
Yes.
Number one, regarding, correct me if I'm wrong, you said underuse of analgesic drug in ED. Underuse.
Yes.
Is that really underuse or inappropriate use of drug or inadequate dose given to the patient?
In this context, the underuse means inadequate use. We did not compare the dosage. In this case, we compare the rate of prescriptions. 44% to us is not very high. Still within the, compared to the other study, it is still within the range, 30 to 63%. So in this case, we didn't compare the dosage, we compared the rate of prescription, and we found out it's inadequate.
The one reason you said why analgesic drug was not given adequately was due to lack of proper assessment. So who did this assessment? The houseman or MOs or specialists?
The patient will first be assessed by the medical assistant at the primary and secondary triage, and we found out that there's no, they don't have a standardized way of assessing the pain. Some use verbal skills such as mild, moderate, severe. Some just ask whether the patient had pain or not. And so it is ideally, we think that they develop a standardized tool to assess the pain. Okay, thank you.
Can I ask very short question? You said earlier that you choose a sample by convenient sampling.
Yes.
Can you explain that, or how you choose this sample?
Convenient sampling is that it means that the population, the patients in our study, it doesn't actually reflect the entire population with pain. We just want to look at the patients with pain in our own ED. So conveniently, we sample the patients in our ED, and in a fixed 2 weeks periods. So this is what I mean by convenient sampling. We recruit the patient by our convenience. Yes. Yes, we attempt to take everyone who come in with pain, but with the high volume of patients, sometimes we do miss a number of patients. That's our limitations of study. We cannot catch all the patients who come in. Okay, thank you.
Thank you, Mr. Nelson Song. Ladies and gentlemen, before we have our lunch break, we would like to thank once again to our panel of judges, Professor Zaleha, Professor Yasmin, and Professor Karis. We also would like to invite all the participants to join our lunch talk by Puan Chandrika Balachandran from Wired Malaysian Sendirian Berhad on knowing what's right for your child. And to all the participants, please collect your lunch at the hallway outside auditorium.